Now, it is my great pleasure to introduce Dr. Teresa Ching. Teresa is a professorial fellow at NextSense Institute and conjoint professor in special education and disability studies at Macquarie University. She is also an honorary professor at the University of Queensland. These are all very tongue twister words. She has led population-based research on speech, language, psychosocial and quality of life outcomes of children who are deaf or hard of hearing in one ear or both ears, including those with or without additional disabilities. So I'll now hand over to you, Teresa, and I'll stop sharing my screen and you can start sharing yours. Thank you.
Thank you, Jane, and hello, everyone. Jane, can you just let me know if the slides have come up? And
yes, the slides there and we can hear you.
Oh, fantastic. Thank you. And hello, everyone. Thank you for joining me at lunchtime. And I am just so very pleased to have this opportunity to speak with you about congenital unilateral hearing loss. I thank Anne Porter. Anne actually was the person who first brought this whole idea of the need, the importance of evidence on congenital unilateral hearing loss several years ago, when we started to see more and more babies identified with unilateral hearing loss. And of course, thank you so much to OCDF Kids for this opportunity to share with you some of the findings from the work that we've been doing and what everybody else have been doing around the world. I also thank our funding bodies for providing the funding for us to conduct the research, and my group, my whole team who's worked with me on some of this research, including those who've worked in the past and those who are still currently working. So I thank everyone who's been working with me on this, on some of the work that I'm going to share with you. I guess we're all curious about how common unilateral hearing loss is. So the answer to this question is actually not simple or straightforward, because it depends on who you ask. It depends on the age group that you're looking into. It depends on the definition of what unilateral hearing loss is. So if we look at newborn hearing screening and we ask how many babies are identified with unilateral hearing loss at birth, we're looking at about 0.8 per thousand. If you look into newborns who are identified with hearing loss, then about 30% of them have a unilateral hearing loss. If you were to ask the same question about school-age children, 6 to 19 years, then the answer is more like 3 to 6%. And you might ask, why 3 to 6? Why isn't 3 or 4 or 5? Like, why are there two numbers there? Well, that's because different people have different definitions of what unilateral hearing loss means. And if you're looking at adults, you're looking at about 7% of the population. Now, interestingly, if you compare the incidence of school age with newborns, you're looking at a 30-fold increase. So you're comparing 0.8 per thousand to 3 per 100, to say the least. In this talk, I'm going to focus on newborns. I'm going to focus on congenital unilateral hearing loss. But first of all, let me come up with a definition of what unilateral hearing loss constitutes. In 2005, many years ago, the United States Center for Disease Control has asked a group of experts to get together, and they did a workshop. And during that workshop, the major thing that they've come up with is a definition of what constitutes unilateral hearing loss. This is an audiogram. So vertical axis, you can see the level in decibels, dBHL, and on the horizontal axis, frequency going from 250 hertz to 8,000 hertz. You see some of the symbols there, the crosses showing the left ear, the circles the right ear, And you can also see some descriptors on the right, like normal, mild, moderate, severe, and profound, which is some of the labels that people tend to give to different degrees of hearing loss. The definition that came up was that a child who has unilateral hearing loss has normal hearing in 1 year, defined as the average of pure tone thresholds from 250 to 8,000 hertz of less than 20 dBHL. So if you look at the audiogram, this is what the circles, the red circles indicate, right? From 250 hertz to 8,000 hertz, you can see that the levels were sort of less than 20. So this is normal hearing in 1 ear, with hearing loss in the other ear, which is defined as pure tone average at 500, 1,000, and 2,000 hertz, to be greater than 20 dBHL. So this time, when you think about the hearing loss, you are only looking at the thresholds at those frequencies marked by the rectangle, 500, 1, and 2,000 hertz. And here, if you take the average of those three frequencies, which is 30, 50, and 70, we say that, okay, this child has a unilateral hearing loss, which is of a moderate degree, so an average of 50 dB. There is a second definition, which is greater than 25 dBHL at 2 or more frequencies above 2,000 hertz. So I've just put it in as those triangles. You can see that for the triangle. Thank you. So with the triangles, you're looking at near normal hearing in the low frequencies, but once you get to 3,000 hertz, it's 40 dB, and 4,000 hertz is 60 dB. So in this case, we sometimes refer to this as a high frequency loss. But generally, the two categories would fall into what is commonly defined now as unilateral hearing loss. So this is important to keep in mind, because sometimes when you read papers, they talk about unilateral hearing loss, but they may have quite a different definition. And so depending on the definition, they might give you different descriptors and different outcomes. Now, our focus today is on congenital unilateral hearing loss. In other words, babies who are identified with unilateral hearing loss soon after birth. Oftentimes, these are some of the questions that parents ask. Will they learn to speak? Does it affect speech and language? Will it get worse? Or will it improve? And what if we choose to wait? Will we disadvantage our child if we choose not to aid? So these are the three practical questions that we're going to address in this talk: impactful hearing loss, how might hearing change, and should hearing devices be recommended? What is so special about unilateral hearing loss is really related to physical effects of the head on the sound reaching the ears. So maybe let's take a few minutes to talk about what are these physical effects. Well, with the human head and the position of the ears on both sides, if a sound occurs on one side of the head in the front, then that sound reaches the near ear faster than when it reaches the ear on the other side of the head. So the time it takes is shorter on the near ear compared to the far ear. And this difference in time of the sound reaching the ears is sometimes referred to as interaural time differences. And based on the size of the head, the interaural time difference can be up to about 700 milliseconds. In the same way, the level of the sound reaching the near ear compared to the level of the sound reaching the further ear can also be different, because the head casts a shadow on the sound. And this is sometimes called interaural level differences. So using these interaural time and level differences, we can use the information to find out, to locate where the sounds come from. So basically, our brain has to do some work there, pulling together information from both ears, and then to figure out, oh, these are the differences in timing, these are the differences in level. And so we think that the sound is located on that side. And the low frequency relates to horizontal localization, and the high frequencies to vertical localization. In the same way, our brain can make use of these interaural time and level differences. So let's look at this picture with the speech, which is in blue, coming from this side, from the right-hand side, and the noise, which is in red, coming on the left-hand side. So if you look at the ear on the right-hand side, the S is very big. So the signal to noise ratio is very good on the right ear. But on the left-hand side, the signal to noise ratio is actually very poor because the noise now dominates. And all of this is because of the interaural level and time differences. So this difference in signal to noise ratio between the two ears is often referred to as a head diffraction effect, which means then that the brain can look at the two signal to noise ratios in the two ears and then decide, the better signal to noise ratio is actually on the right-hand side. So I will attend to the ear on the right-hand side and use that input. Now notice that it is important for the brain to be able to compare the two ears to make that decision. And through combining the input from both ears, the brain can actually partially suppress the effect of noise on the speech. So this is sometimes called binaural squelch effect. And because there is input from both ears, there is a summation. The two ears add up. So listening to it 2 times means that there is also a benefit of 1 to 2 dB. So keeping those things in mind, the impact of having a hearing loss in one ear means there is reduced audibility in one ear. So one of the ears cannot hear soft sounds or softer sounds. And yes, you can fit a hearing device to that ear to increase the volume so that you can hear it better. But the second effect, which is actually the very important effect, and that makes this unilateral hearing loss such an important area, is that there is also the reduced effect of binaural hearing, those interaural level and time differences that we were talking about. And so not being able to hear very well in one ear does not only reduce that audibility, it is that reduced audibility, which means that the listener does not have access to all of those binaural effects that we were talking about, the head diffraction, the binaural squelch, and the binaural summation. And such deficits may potentially lead to problems. And I said may potentially because our brain is a very dynamic system and it actually does very fantastic things, and it can actually adapt to some distorted cues. Now, the extent to which one can do that really varies from individual to individual. So let's start keeping those information in mind. Let's start to address our 3 questions. The first question. There's been a couple of systematic reviews on the impact of unilateral hearing loss on speech and language development. So these are a couple of those. There's also a third one, which is published in 2019. The first 2 studies collated a lot of information, but as you can see, they've only found 4 studies in the first one, 11 studies in the second one, and in the third one, there were only 3 studies. The difference, though, is the first couple of studies focus a lot on children with unilateral hearing loss, whether they are congenital or early onset, whereas the last one focused only on congenital hearing loss. So since the publication of that review in 2019, there were a few more studies, which I have now summarized in this table for you. I particularly would like you to look at the ones where there is a wriggle with NH in blue. They are the areas, and as you can see right across the top, language, speech production, whereby there were 2 studies that suggest that children with unilateral hearing loss, on average, achieve language and speech production within the normal range. Functional performance, the next column, is another one where it says that one of the studies showed that the children with unilateral hearing loss performed within the normal range in quiet situations, as reported by parents. But notice that in that same column, 3 studies reported that those children actually functioned poorly in noisy situations. So they were good in quiet, but not so good in noisy situations. It would not be surprising, of course, if we think about those interoral level and time differences, which were not available. Auditory comprehension, again, the same story. So the children with unilateral hearing loss were functioning like normal hearing children in quiet and 6 dB signal to noise ratio, which is a fairly good signal to noise ratio, but they were poorly when they were functioning in lower signal to noise ratios. Speech perception, the next column, localization is poorer. And then the next column, speech perception. If you present speech to the good ear, they were like normal hearing children. If you present speech to the poorer ear, they were poorer. And the last paper, McSweeney et al. 2021 focused only on children with profound, mainly profound unilateral hearing loss, or sometimes referred to as single-sided deafness. And they found that the performance of children in educational outcomes, such as reading, maths, visual spatial memory, was similar to children with bilateral cochlear implants. So profound loss in both ears, but with implants. And definitely both groups were poorer than normal hearing children. I want to remind you that some of those systematic reviews actually included studies that summarized information from children with congenital, early onset, late onset, and acquired unilateral hearing loss. And recall in the very first slide, when I talk about how common it is, I did talk about how when you look at school-age children, you're really looking at a 30-fold increase of unilateral hearing loss. So some of those children have different etiology, different causes, different degrees of hearing losses. They've had the opportunity to develop early speech and language. So the consequences of unilateral hearing loss on those children are likely to be different from those who have congenital unilateral hearing loss. So for that reason, we followed 34 children diagnosed with congenital unilateral hearing loss. So these were children who were identified via the SWISH program in New South Wales. So they were all identified with unilateral hearing loss at birth, and we followed their development over many years. 34 of them, and shown on this graph is the number of children with different degrees of unilateral hearing loss. So when we first of all look at the blue columns, we can see that quite a number of those children at diagnosis had mild losses and moderate loss in their ear that is affected, and less children with severe and profound losses. At 9 years of age, when we got in touch with them, look at the orange columns. We have a few who've now got normal hearing. We have a reduction in the number of children with moderate losses, but an increase in the number of children with severe and profound losses. In fact, when we contacted them, about of the 34 children, 19 were aided, 16 in one ear, 3 in both ears. And the mean age of fitting was around 5 years of age. It is interesting that it is that preschool age that Hearing Australia in Australia actually had a second peak of fitting, especially for children with unilateral hearing loss and milder hearing losses. 15 of those children remained unaided. They were not wearing any devices. So we did a whole lot of assessments of these children, including receptive vocabulary, PPVT, receptive language and expressive language, the self-test, language memory, the self-test. This is core language on the self. And these are all standardized tests with norms from the Australian population. WNV, which is nonverbal IQ, and then word reading, non-word reading, and passage comprehension. Now, this graph has on the vertical axis standard scores. So with a standard score, 100 is the mean. So normally hearing, typically developing children would have a mean of 100 on all of these tests and a standard deviation of 15. So the green band marks what we loosely describe as the normal range. So if you look at the performance of this group of children, these 34 children identified with congenital unilateral hearing loss, the triangle is where the mean is, and that's the standard deviation. So you can actually see that all of them were actually performing within the normal range, regardless of whether they were fitted or not fitted. The only difference that was significant statistically was passage comprehension, but even though it was still within the normal range. We also assessed speech perception in noise. In particular, we wanted to look at that use of binaural hearing ability, the use of interaural level and time differences in perceiving speech in noise, because we know that if they have deficits in that ability, they're going to have problems in noisy situations, such as learning in the classrooms. So the way that we measured speech perception was, first of all, by presenting speech and noise from the front, facing the child. And then presenting speech from the front, but noise from both sides. In typically developing children, when you move the noise away from the speech source, they can actually make use of those interaural level and time difference to use those binaural hearing information to help them hear speech better in noise. In fact, we measured a group of normal hearing children, and we found that when speech and noise from the front, they could get 50% correct in that sentence test at -2.5 dB signal to noise ratio. Now, this is measuring signal to noise ratio. So the lower the score, the better is the performance. And when we move the noise to the sides, they actually gain an advantage of 3 dB. And 3 dB is a lot in terms of, if we think about a sentence test in terms of percent correct score, then 1 dB is about 10% correct score for children of that age. So that's a big advantage if you're able to access those binaural hearing cues. We measured speech perception in noise in this way for our group of children with unilateral hearing loss. So remember, lower is better. And for each child, there are 2 columns. There is the blue, which is for the speech and noise from the front. And there is the orange, which is the speech with noise in spatially separated locations. Remember, lower is better. So we're looking for a green column, an orange column, which is lower than the blue column. And in fact, if we look at all the children and the individual scores, there were 11 children who demonstrated that ability. So when noise was moved away from speech, they could actually hear the speech better. How well could other people understand this child's speech? Can they speak and can they produce intelligible speech? Well, in fact, we're looking at around 91% of the children who produce highly intelligible speech, like typically developing children. What about their functional performance in real life? Well, we ask parents to rate how well children function in everyday listening environments, in quiet and in noise. Now, shown on this graph is a Z-score. So a Z-score of 0 means that they were like normal. And then we have +1 standard deviation and -1 standard deviation. So a score within this whole rectangle shows that the children were performing at normal, within the normal range. And when we look at the blue columns, which is based on parent ratings, so notice that they are all within this rectangle, so all within plus and minus 1 standard deviation of the normative mean. Notice, however, parents rated children to be performing more poorly in noisy situations compared to quiet situations. But interestingly, if you look at the orange columns, which is what children did when they do their own rating. So because these are 9-year-old children, we actually gave them a questionnaire, the same questionnaire, but this time asking them to rate themselves as to how well they function in everyday life. And they really consider that they function like normal hearing children. We also measured their behavior and emotions, their psychosocial development. So using a questionnaire, which is called the Strengths and Difficulties Questionnaire, or the SDQ. So this is based on parents' rating. And again, you're seeing the Z-score here. A 0 is the normative mean and plus and minus 1 standard deviation. Now, the Strengths and Difficulties Questionnaire has got different subscales. So emotion, conduct, hyperactivity, peer relations, pro-social behavior, and it gives you a total score. And the interesting thing is that they all had ratings well within the normal range. So they're not any different from other children who are typically developing. We also measured the quality of life, and we used the pediatric quality of life, or the PETS-QL. And this is, again, a parent report tool, which is based on 23 items. And if you look at the magenta ones, the columns, notice that parents rated children to be well within plus and minus 1 standard deviation, so really within the normal range. And we also asked the children to do the same questionnaire. And again, notice how the parents' ratings and child ratings were really quite similar. And both of them rated their quality of life to be like normal. So in summary, when we asked the question about congenital unilateral hearing loss on children's performance at 9 years of age, school age, our results show that their spoken language ability, their functional performance, their psychosocial skills, and their quality of life were all close to normal. They are well within the normal range. Yes, their speech perception was poorer than normal. In fact, about half of them were not able to make use of binaural hearing cues, so they had huge difficulties when listening in noisy situations. When we look at what predicted their performance, it wasn't the degree of hearing loss, it wasn't which year their hearing loss was in, it wasn't about whether they were using devices or not, it was just the nonverbal IQ that accounted for the outcomes of those children. And this is really not dissimilar from our research that on children with bilateral hearing loss. Our second question: will the hearing get worse? Will the better year deteriorate? Or will it improve? It has long been known that in permanent childhood hearing loss, that the hearing loss does change over time. There's been a number of studies, and the proportion of children that demonstrate progressiveness of hearing loss is anywhere between 10 and 50%. Again, people differ in the way in which they define progressiveness, in the way that they define what constitutes deterioration. The studies also differ in terms of how long you follow the children. Is it just for 1 year after diagnosis? Is it up and until 18 years of age? Is it over 10 years? Like the duration of follow-up differs. And most of those studies included, again, children with not only congenital unilateral hearing loss, but also children with early onset, late onset acquired hearing losses. So it's difficult to figure out what actually applies to only children with congenital unilateral hearing loss. So for that reason, we followed 91 children who were diagnosed with congenital unilateral hearing loss and who enrolled in a study that we conducted on outcomes of children with unilateral hearing loss. All of these children were diagnosed at birth via newborn hearing screening programs. So this gives you an idea, this breakdown gives you an idea of the kinds of degree of hearing loss that applies to the population of children with congenital unilateral hearing loss. Roughly 29% have profound loss and 15% have severe loss. So really looking at about 45% of them having a severe to profound hearing loss at birth, and the remaining have mild to moderate hearing loss. High frequency hearing loss is very scarce, so you're only looking at 1% there. The study then looked at comparing that first estimated hearing loss from diagnosis with the first behavioral audiogram that we were able to obtain from these children with congenital unilateral hearing loss. And all of these children were attending services at Hearing Australia, so the audiograms were obtained from Hearing Australia with permission from parents. I've shown here a histogram, a chart, that shows the number of children whose first behavioral audiogram was obtained at each age mark. And we found that the mean, the overall mean average of age at which children obtain their first behavioral audiogram was actually 3 years of age. Imagine they were diagnosed at 2 months, but we did not have a reliable behavioral audiogram until they were 3 years of age, from only 48% of the children. And in fact, for the remaining children, we didn't get that first behavioral audiogram completed until they were about 6 or 7 years of age. So it was a really long time duration between diagnosis and the first reliable behavioral audiogram. So what is the proportion of children? Do the hearing change? Does the hearing change over time? Well, again, it depends on how you define that deterioration. One definition, which has been adopted in many studies, is looking at a change of 20 dB or more in the pure tone average of 500, 1000, and 2000 hertz. Remember in the first slide when I show you that rectangle, that free frequency average? So it is looking at a change of 20 dB in the average of those three frequencies. And if we were to look at just the average of those three frequencies, then only 26% of the children showed a deterioration between diagnosis and the first reliable behavioral audiogram. 72% remained stable and 2% improved. If instead of looking at an average degree of loss, we look at individual frequencies, and this time we adopt the rule of a change of 10 dB or greater at 2 or more frequencies between 500 and 4,000 hertz, or 15 dB or greater at one frequency, then the picture is very different. And why are we looking at 500 and 4,000 hertz, you might ask? Well, that's because those are the frequencies that have been found to be most important for understanding speech. So if we look at individual frequencies or any one or two frequencies and looking for differences of 10 to 15 dB or greater, then we're looking at 78% that showed a change. Remember, the previous, based on average, was 26%. If you were to look at individual frequencies, we're looking at 78%. So you might ask, why is it important then to look at individual frequencies? Well, because the loss and the change in individual frequencies are going to have an effect on how you, the parent or the child, might consider managing that unilateral hearing loss. Your options may change. You may decide to do different things because you're starting to see a change in the hearing levels. If we were to focus on that 78% of children who show hearing deterioration, then we can see that majority of those children actually had a deterioration in the impaired ear, in the ear that was affected. 53 of them out of the 69 show a deterioration in two frequencies. And 16 of them show deterioration of more than 15 dB at one frequency. And of the remaining two children, they actually subsequently developed a hearing loss in both ears. So we actually found that most of the changes that occurred during the first few years of life. And this is in accordance with some of the other studies that have reported similar findings. And in the children in which we look at specific hearing levels at different frequencies, we're looking at 78% of the children who would experience some loss during the first few years of life. Our third question: should we choose to aid or not to aid? Will it disadvantage the child if we choose not to aid immediately, soon after diagnosis? There are a couple of systematic reviews, one that focuses on BAHAs, bone-anchored hearing aids and FM systems. There were only 12 studies included in that systematic review, which was published in 2017, and very variable outcomes, very little data, and perhaps the only thing that seems to make sense is that remote microphones provide most benefit. In a subsequent systematic review, this one focusing on single-sided deafness, which included 12 studies that suggested that cochlear implants may be helpful. Again, I need to caution you, when you read these papers, when you look at the data that they provided, because in studies that compared aided and unaided participants that were not randomly assigned to the two groups, then those results do not allow conclusions to be drawn about the effects of aiding. This is because there could be some underlying reasons, some inherent characteristics in the aided group and the unaided group, which led to the one group being aided and the other group being unaided. And so those same factors could potentially affect the outcomes of the participants. So really, no conclusions can be drawn unless you're really looking at randomized controlled trials. There was one randomized controlled trial looking at hearing aid use. And this particular one compares use of hearing aids with remote microphones compared to use of remote microphones only. So this is not aided, unaided. This is hearing aid plus remote microphone compared to remote microphone only. This is a very small study, only 34 children, divided into 2 groups. And the way in which they measured the outcomes was based on parent reports, which included a quality of life measure, and then 2 questionnaires, one called the child and the other one called the life. Now, let me take you through this picture. This picture, you can see in the filled circles, there are pairs of circles. So this is for the filled circles, the first group, which they call arm 1, is baseline. So this means that the children were using remote microphones only. And they did 2 measures in the beginning and then after 12 weeks. And then they fitted hearing aids to the same group of children, and then they did 2 measures again. Now, the statistics shows that the very first measure and the very last measure were different. The remaining ones were not different. In the second group, now these are children who tried hearing aids first, again 2 measures. And notice that when they were trying hearing aids, the second measure was actually significantly better than the first measure, although the listening condition has not changed. And then they took away the hearing aids and the children used remote microphones. And they found that the last measure, when they used hearing aids, was significantly different from the first measure when there were no hearing aids. So what this is suggesting is that there is a crossover effect because of the changeover and because of the measures. No clear conclusions can be drawn about the benefits of fitting a hearing aid when the children were using remote microphones. The paper, however, lump all of the hearing aid measures together and lump all of the hearing aid plus remote microphone measures together, and they found a significant difference between those 2. So average across both arms, as concluded by the study, the questionnaire scores were higher during the hearing aid trial period than baseline. And this trial period was for 12 weeks of observation period. There were no other randomized controlled trials, but there is one that I wanted to share with you on children with single-sided deafness, because it looks at children with single-sided deafness who use cochlear implants and compare them with children with single-sided deafness who do not use any device. So the orange, 15 children with single-sided deafness and cochlear implants, and the green, 16 children with single-sided deafness that are unaided. And they had a group of 30 children with normal hearing. So on average, they found no significant difference in receptive language and vocabulary among the groups. So groups were within the normal range in receptive language and in vocabulary. They did find that the group with cochlear implants had better grammar compared to the group without cochlear implants. Keep in mind, of course, that as I mentioned previously, that this is not a randomized trial, so there could be some inherent characteristics which led to some of these findings and outcomes, which are not directly related to the presence or absence of a cochlear implant. So we commenced a randomized controlled trial of hearing intervention in 2017 and started recruiting then, when babies with unilateral hearing loss were identified by newborn hearing screening programs in Australia, but the data collection is still in progress. So I can show you some overall results at 3 years of age. This is for the whole group of children in the study, with a standard score shown on the vertical axis, a mean of 100, and a standard deviation of 15. So the green band is the normal range. We looked at receptive vocabulary, PPVT, which is sitting squarely on the normative mean of 100. Receptive language from the preschool language scale, the PLS. Expressive language from the same test. Consonant production from the deep test. Vowel production. And then we also ask parents to rate how well children function in everyday life, the quiet and noisy situations. So we can see that most of the measures, the vocabulary, the language, the speech production were within the normal range, as well as the functional performance in quiet was within the normal range, but functional performance in noise was below the normal range. We also interviewed parents soon after detection and when they enrolled in the study. And some of the things that parents told us was that they experienced much uncertainties about the condition, about the future of their child, and about whether hearing changes. They thought, though, that it was good to know early because it allows them to consider access to other types of early childhood intervention to support their child if need be. They also found that guidance and encouragement from health professionals were really useful, and they really appreciated that. However, they also found that sometimes the information that they receive can be quite confusing and conflicting. And they have concerns about the extent of the unilateral hearing loss, as well as about the recommendations that different professionals were telling them. We interviewed the same group of parents again at 3 years of age. And the parents told us now that they have considerably reduced level of concerns about their child's future. They feel that they are better equipped with information to make decisions. They recognize the importance of ongoing management, and management needs to change over time. And they feel that they have adjusted to a new normal, which is defined by their children's unilateral hearing loss. There is definitely a shift in perception. They've reconciled with their previous expectations of their child. They are ready to explore all options, given the uncertainties about progression. And they're willing to try all sorts of interventions, including hearing devices. Some parents even considered learning Auslan because they said they don't know whether they might need it in the future, so they want it as a kind of a backup. And parents often tell us that they really wanted their child to make those decisions about whether they want to wear a device or not. And in fact, the idea of it's not so much the hearing levels, it's more like family considerations and child considerations and characteristics that seem to be the underlying things that prompt them to think about should they aid or should they not aid that unilateral hearing loss. So coming back to the 3 questions that we started off, our current data suggests that in children with congenital unilateral hearing loss, their spoken language ability, their psychosocial skills, their quality of life, and the nonverbal ability appear to be typical. They've definitely demonstrated some binaural listening ability in some instances, but in many others, this ability was much reduced. And so this is manifested in the reduced speech perception ability in noise. And in one of the studies, they've actually reported that focused listening in classrooms can be quite difficult. This suggests to us the importance of continually monitoring the development of the children, and remote microphones help, particularly when children are out and about, they are in noisy situations, and they need to learn in those situations. Our data on following children with congenital unilateral hearing loss suggests that hearing levels do change over time. And in fact, the changes do occur within the first few years after diagnosis. So rather than to wait till 4 or 5 years of age before you start considering whether you wanted to go back to have a hearing assessment, I would suggest that you monitor those hearing levels very vigilantly earlier on, because if we're looking at changes at individual frequencies, our data suggests that about 3/4 of the children would demonstrate some change over time. And it is important at every time that you see those changes that you reconsider management options. Thirdly, families tell us that they need ongoing guidance. So yes, it was very helpful to receive all those information and guidance earlier on, soon after diagnosis, but the needs of the children keep changing as they grow, so they need ongoing guidance. An important aspect is also that families tell us that we need to do what is right for the family and the child. We need to provide individualized support, and support needs to be ongoing. Regardless of whether you consider a hearing device for the child who is affected with unilateral hearing loss, the two pieces of advice that are most important to help the child grow is, one, to provide a rich language exposure to your child, regardless of whether they were wearing a device or not. There is now emerging evidence and accumulating evidence to suggest that a rich language exposure is critical for normal language development, not only for children with hearing loss, but also for typically developing children. And it's particularly important for children who have some hearing impairment to actually have that rich language exposure. And we don't mean really sort of turning the TV on and watching videos on iPads. It's really that interactive exchange of language that helps a child to make sense of the environment and to learn speech and language. Secondly, remember to position the speaker to the good ear of the child. Again, regardless of whether the child is wearing a hearing device, even if the child is wearing a device in the ear that is affected, the normal function ear is still the ear that is going to provide the best possible input. So always remember to position the speaker to the side of the good ear. This is a list of some of the references that I have briefly mentioned in a talk. I'm happy to provide a copy for some of you who may be interested. I'm going to stop here, and I'm happy to take any questions that have come from the audience. Thank you again for listening, and I look forward to sharing with you the findings from that longitudinal study on children with unilateral hearing loss when we complete the collection of data next year around mid-year. So we'll be able to analyze the data and we'll be able to share with you the findings from that study. Thank you again for joining me.
Thanks so much, Teresa. Can I get you to keep your slide on, because we've got a few questions that actually relate to your slides.
Sure.
Refer to them. So yeah, we've got quite a few questions. If we don't have time to get through them all, I'm sure we can answer them by email later